Welcome to Morning Pointe's virtual Caregiver Cafe series. I am Rachel Smith, and I will be your host for today. Here at Morning Pointe Senior Living, we believe information and education move people forward. That's why we continue to open doors and connect with community leaders, medical experts, and senior living influencers. This helps seniors, families, and the future workforce better understand the challenges of aging, as well as the support and resources that are available. Our goal with each Morning Pointe Foundation Caregiver Cafe is to increase public awareness for senior caregiving needs and challenges, and support educational, clinical, and wellness initiatives that strengthen caregivers. We would like to thank the Morning Pointe Foundation for collaborating with us to make this exceptional event happen. And now I would like to introduce Audra Hopkins, Executive Director of the Morning Pointe Foundation.
Thank you, Rachel. Hello and welcome. The Morning Pointe Foundation is a 501c3 nonprofit public service organization that provides caregiver support programs, sponsors educational awareness events, and funds clinical scholarships to advance the care of seniors. The foundation focuses on three main components: caregiver support and training, educating a future workforce, and leading the way. The foundation collaborates with 10 schools across the Southeast. Since 2014, we provided scholarships to over 60 nursing students. I would like to thank our ongoing sponsors for our Morning Pointe Foundation Caregiver Cafe series: First Horizon Bank and Propel Insurance. These sponsors help us achieve our goal of supporting nursing students and providing educational programs. If you would like to donate or learn more about the foundation, please visit the Morning Pointe Foundation website.
Thank you, Audra. During this event, we encourage you to ask questions via the chat button available in the Zoom application. The presenter will receive the questions and address them following the broadcast. You will receive an email following the event with answers to all questions submitted. Please sit back and enjoy our virtual Caregiver Cafe series.
Good evening and welcome everyone. Welcome to Understanding Alzheimer's and Dementia with neurologist Dr. Matthew Kodsi and our memory care experts. I'm Amy French and I'll be moderating this event on your behalf. As Rachel explained, it's very simple the way this works. It's quite simply a question and answer. And that question and answer time will allow you to get the information that you need and want, and not only for yourself, but also to share with others in this group experience. I'd like to introduce Dr. Matthew Kodsi. Dr. Kodsi is, of course, our keynote speaker this evening. And Matt, would you like to say hello?
Hi, thank you so much for having me. I appreciate the opportunity. I'm always happy to try to address questions from the community.
Of course. We're delighted to have you here. I'd also like to introduce our other panel of experts. We have joining us this evening, Beth Janney. Beth, would you like to say hello?
Sure. Good evening and welcome. I am Beth Janney. I am a registered nurse and the corporate director of memory care for Morning Pointe. I have been a caregiver. Therefore, it is my personal and professional mission to improve the quality of life for those people living with dementia and their caregivers. Thank you, Amy.
Thank you, Beth. We also have joining us Ashley Briggs. Ashley, would you like to tell us a little bit about yourself?
Absolutely. Thank you for everyone being here tonight. I'm Ashley Briggs. I'm the Lantern Program Director for our Franklin, Tennessee Morning Pointe campus. I have worked in dementia programming for 14 years, 9 of those being with Morning Pointe. And I have a strong passion for providing meaningful programming for those living with dementia.
Thank you, Ashley. Thank you for being here. As I mentioned earlier, the format for this event is very simple. It is exactly what it says it is. It's a question and answer. And we thought we would start with some of the basic questions, the topics that we're going to discuss. You can see the list in front of you here, but please remember, the chat is for you guys to ask your questions, and I'll be checking periodically with Rachel on what the chat questions are. So to cover the topics of discussion, we'll include what's the difference between Alzheimer's and dementia? What are the risk factors of Alzheimer's disease? We'll identify the 3 stages, and we'll talk about the latest FDA-approved treatments. And of course, we'll always cover the resources that are available to help. Dr. Kodsi, let's start with the most common question that we get. Let's talk about the difference between Alzheimer's and dementia.
Sure. So I think a lot of people get those terms a little confused, and they think that they mean something different. So when we talk about dementia, dementia is not really a disease. Dementia describes the symptoms that someone has when they have problems with their thinking. So the similarity that I draw when I talk about dementia, saying dementia is like saying car. If I say to you, there's a car in the road, you don't have to see that car to know that it's got 4 wheels, probably, a motor, it gets you places. For now, it probably runs on gas, electric maybe. When you say someone has dementia, it also has a description, and it tells you that that person has problems with their memory that make it difficult for them to be independent. And they have problems with some other areas of thinking, be it planning, be it orienting, knowing where they are or how to get places, be it math, making change when they go to the store. But these problems, as I was saying, make it difficult for them to be independent, and they need assistance. So that describes someone who has dementia. So much like if we go with the idea of a car, if I said to you car, you don't really have a full image, but if I said, oh, it's a Honda Odyssey, or it's a Toyota, gosh, I haven't owned a Toyota in a while. It's a Toyota Prius. You know exactly what that looks like, and you know what type of car it is. Likewise with dementia, when we talk about the types of dementia, Alzheimer's being one, those are the diseases that cause the memory problems. So the most common cause of dementia is Alzheimer's disease. But people can have dementia from things such as strokes, Parkinson's disease, and other diseases that can cause memory and thinking problems. So Alzheimer's and dementia are not different. Alzheimer's is one cause of the symptoms of dementia.
That makes a lot of sense. So everyone has what we like to call our memory problems, right? We walk out of Walmart and forget where we parked our car. We walk into the kitchen and forget why we walked in there. How do we know if we need to worry about ourselves or our loved ones?
Sure. So there's a lot of different perspectives on how to clarify that question. One is, of course, if you can't remember where the car was, you stop, you think a minute, and it comes to you, unlikely to be a major issue because you're able to recall. People have Alzheimer's disease. When they forget something, they're very unlikely to be able to pull that up in the moment. But I think another thing, and probably the biggest thing we look for as physicians, is we look for change. So if there's something you've always done well, I had a patient, for example, who was an accountant, and they began to have difficulty with math. Well, mild problems with math, maybe we all have a little bit, but for someone who made their life or whose life career was numbers, for them to have trouble with math, that's a sign that there may be something more concerning going on. So if there's something that you've always been good at that involves thinking, memory, orienting, and now you're starting to have noticeable trouble with that's probably the time to get checked out.
I see. Rachel, let's check in with our chat. I see a lot of questions coming in.
We're getting some great questions coming in, and one of these ties in, I think, fairly closely to what Dr. Kodsi was just talking about. And Aaron is asking if it is important to know the cause or what disease is causing a person's dementia.
So that's a yes and no. In many types of dementia, the treatment does not change. So it doesn't really affect the treatment. However, I would say that if someone has dementia related to strokes, then the treatment may be very different, because in addition to medicine for the memory, then we're going to want to use medicine to prevent more strokes. Also, different dementias progress differently. The symptoms can vary a little bit. The time course can vary. Some are a little faster than others in terms of getting worse. So I think it's helpful for the family members to understand what to expect over the course of the disease. So in those ways, I think it is helpful to know what the cause is, if possible.
So if I were worried about myself or my loved one, what would be my first course of action? Let's say that I've determined that the things that are going on do show a significant change. But I also know, I mean, we've got COVID going on. We've got, we're all getting older. My husband, let's say he's diabetic now. What's my next course of action?
Sure. So I think obviously the most important thing is to bring this up with your physician. And many family physicians are certainly very capable of making a diagnosis of Alzheimer's or some other types of dementia. Some feel that they would like to get a second evaluation by a specialist, like a neurologist, or in some cases, a psychiatrist. They also can evaluate dementia. And so starting with your family physician, either pursuing the evaluation there or getting a referral then to a specialist. I think honestly, the most important thing you can do if you or your loved one is having memory or thinking problems and there's a concern is, number one, don't go to the physician alone. The person with the memory problem should not be the only one in the room. And I say this, and people, I'm sure, probably 100 of the 151 people on are smiling, thinking, really? It happens. And it happens understandably for a lot of reasons, because it's awkward. The family member may feel uncomfortable speaking openly about the concerns with the individual in the room who's having the memory problem. So it's an awkward situation. They may not realize that the physician has questions for them. And it is really essential that the physician get as much of the story as possible. And unfortunately, when the individual has memory or thinking problems, they're not going to be able to tell us just how impaired they are unless we have family there to give us those details. If you find it awkward or uncomfortable, then write them down. Write them down and get them to the office, get them to the physician beforehand, bring them to the appointment. I would say my one recommendation, and Amy's heard me say this over and over again, is unfortunately, I wish it were different, but the physicians only have a limited amount of time. So 4 pages single spaced is unlikely to be read, not in its entirety at that time, maybe later. Dot points, 1 page, just key points about concerns and things that have been noticed so that the physician understands what you're worried about.
Yeah, and I think what you're saying is true. You circle back to what's changed. What is leading us to come to the doctor at this point in time? And I tell folks, pick your top 5. There's probably a myriad of things that you're concerned about, but pick your top 5. And like you said, I think it's so important. I've heard you say this many times, Dr. Kodsi, doctors can only treat what they know is happening. I can't tell you the time that I get calls from caregivers who say, Daddy's getting lost. He doesn't know who the grandchildren are. And I finally got him to go to the doctor, and the doctor didn't do anything. And it's most likely because the doctor didn't know what was going on. So that communication is so very, very important. Very good point. Rachel, can we check in on chat again?
Absolutely. As we were talking about things that have changed with a parent or a grandparent, Heidi's saying that she has a parent who did not really show any symptoms till after 1 year of COVID lockdown. So this is very timely for all of us. And she's asking, how do I tell if just coming out of shelter in place type symptoms are the same thing as actual dementia and Alzheimer's symptoms?
It's a very fair question. And I think all the more reason, if you're concerned, go ahead and get it evaluated. If you are concerned, get your family member evaluated. In that situation, best case scenario, they say, I don't see any signs. There's no problems here. Give it a little time, see if it improves now that they're getting fresh air again. Also, it is a good thing to get evaluated early. So if there is a problem, getting evaluated early can be helpful as far as response to medications, community support, other things. So either way, getting checked early if there's a concern is the best thing to do.
Yeah, early detection, early diagnosis, early intervention is the key to managing any kind of chronic illness. And when we were talking about, the difference between Alzheimer's and dementia, Alzheimer's dementia specifically, and many others too, are progressive. And the medications that are on the market now can't reverse that progression. The hope is that it could halt. But rather than me talk about that, Dr. Kodsi, can you talk a bit about the medications?
Sure.
What can be expected?
So unfortunately, it really hasn't changed in many years, although I know they're looking at new things. So there are two different groups of medication that are used to treat Alzheimer's disease specifically, although we do use them for some of the other dementias. And one group, I'll start there, has only one medicine. So we'll start with the one that only has one. And that medicine is Namenda, or memantine is the generic. And I should point out that all of these medicines are now available in generic form. So the memantine, it acts to decrease a chemical in the brain that we believe may well be a little overactive. It's a chemical that works in the memory circuits and you got to have it. But if there's too much of it, it can actually cause damage to the brain itself. And so there's some theories that it may be too high, causing noise in the system, and maybe causing some of the damage. And so this drug brings that chemical down theoretically to a more normal level in a sense. And it has been shown to be helpful. Now, when we talk about all of these medicines, I'll go ahead and say, what do we mean by helpful? Do we mean their memory is going to get dramatically better? Do we mean the disease is going to stop in its tracks? Honestly, neither one of those are what I expect with these medications. I hope for some improvement. I really do. My goal is stability, so I can keep people stable as long as possible. And in the end, what we can really, really hope for is that we're slowing the decline. Because these medicines do not treat the disease itself. They treat what's going on in the disease. So I said that chemical may be a little high. That's not what's causing Alzheimer's. That's a byproduct of the disease. And so we're treating that. The other group of medications, there are 3 medicines in there. And number 1 is Aricept, or donepezil is the generic. It's one of the first that ever came out. Then there is Exelon, or rivastigmine. Don't try to spell that. And then there's another one that really isn't used as much because it was the last to come out, but it's just as good. It's just not as popular anymore. It's called Remenil, or galantamine. And I can tell you that these drugs are available in pills, in orally dissolvable tablets, in liquids, and in skin patches. So you've got the gamut of options for how to get the medicine to be taken. Now, these drugs all work the same way or similarly. They increase the chemical in the brain that's essential for the memory circuits to work, but that we know in diseases like Alzheimer's disease that the parts of the brain that make this chemical are parts that are being damaged by the disease. So that chemical level is dropping. And in some ways, if I come back to the car analogy, imagine it's like an oil leak. We're not fixing the leak, but we are continuously pouring more oil into the tank or into the car to try to keep the level up. And that's what these drugs do. They try to keep that level up without fixing the actual leak or the damage. So again, hoping for stability. And we do see that often for several years, really, really aiming to slow the decline. So I will say that the standard of care is to combine these 2 types of drugs. So the Namenda, or memantine, should always be given in combination with either Aricept, Exelon, or Remenil, because they work in different ways, but both can be helpful. Are there situations where someone can't tolerate a medicine? Certainly. So they might only be able to take one type, but the goal is to try to combine them.
Thank you, Dr. Kodsi.
Sure.
Rachel, let's check in on chat.
Sounds good. This ties in with what Dr. Kodsi was just talking about related to medications. And Rudy is asking, can a primary care physician prescribe medications for memory loss, or do you need a specialist for that?
Absolutely. Primary care physician can make the diagnosis, write the prescriptions, and you may never see a specialist. I think only if they are not quite sure, or they would just prefer to have that second perspective, that they send a patient to a specialist.
Yeah, and I would add to that, primary care physicians are usually need to be your first line of consultation, because there are other things that can cause dementia that might, or exacerbate dementia that might need to be addressed, like unmanaged diabetes or things like dehydration. There are all kinds of things that can and do impact our ability to think and function and remember. So it's really important to do that. And I also want to mention that for everyone who is on Medicare, their annual wellness exam should include a cognitive evaluation, even if you're not having problems. Doctors can bill for that service. It is not asking the doctor to do a favor. It is part of the annual wellness exam. However, generally, you have to ask for it because it is a little bit more time consuming, and it's perfectly reasonable to ask for it. And that allows your physician to maybe allow a little bit more time for you to come back and do some of the cognitive testing and things like that. So, and speaking of cognitive testing, Dr. Kodsi, can you give us a little bit of insight as to what that visit might look like?
Sure. So as I said earlier, the most important thing is to really get the history, the story of what's going on. So you need to have more than one person in the room. And more times than not, we can make the diagnosis just from that story. But at the same time, we want to do more evaluation. So the exam is going to consist of a normal physical exam, in addition to a standard set of questions in usually what's called the MMSE, the Mini Mental Status Exam. It's a 30-point test, and it's standard what score you would expect for different people at different ages. So we know if there's a problem, if the score is lower than we expect. That said, once we see that there's a problem, there's a number of tests that we do standardly. One thing is we check blood tests for what we call reversible causes of dementia or of memory problems. There are certain hormone deficiencies, vitamin deficiencies, and other things that, if the levels are off, can cause memory and thinking problems. Thyroid is a classic example. If the thyroid is very low, it slows you down. It slows down your thinking. You become forgetful. So if someone has a very low thyroid, well, we replace them with medication for the thyroid and they can return to normal. So we do those tests to look for those things. In addition, we do a picture of the brain. So people hear about lots of different pictures: CAT scan, MRI, PET scan. Really, my preference is to do an MRI of the brain. And I say that because if I make the comparison, to me, a CAT scan is sort of like taking a black and white photo and looking at it from about 10 feet away, whereas an MRI is like taking a high resolution color picture that you're really looking at well. It just gives that much more detail. And what I'm looking for is a few things. So with an MRI, I can also look for areas of old stroke damage to the brain to say, are there signs of old strokes that could be affecting the memory? And I can also get a really good look at the parts of the brain involved in diseases like Alzheimer's disease and look to see if there is shrinkage down of those areas. Because as the disease progresses, it causes those areas to shrink as they're damaged. So I can get the best look with an MRI, and that together with the exam and the story and the blood test will tell me 99.9 times out of 100 whether this is most likely Alzheimer's disease or not. There are other more detailed evaluations that can be done, and sometimes we need those.
I see. I'm actually doing a little bit of cheating here, on Rachel, I saw a question that asked about those challenging behaviors that occur, like combativeness, like hallucinations, like behaviors that are difficult to manage. Can you address that a bit?
Sure. I mean, I think in general, we try to avoid medication to treat behavior if we can. And to that point, though, if they're not on memory medication, being on the memory medication may help the behavior. So that's the first thing I do is I, of course, try to treat the process. I treat the Alzheimer's with Alzheimer's medication. If that's not helpful, in a sense, by clearing up the thinking a little bit and decreasing the behavior problems, then you really do try to look for any triggers to the behavior. If they get upset only when Cousin Joe comes over, then maybe Cousin Joe shouldn't come over. If they get confused at certain times of day because of disruptions in routine, then maybe we need to make the routine more set. Routines are incredibly important for people with Alzheimer's disease because they're used to a pattern. And if you deviate from that, they can't always adjust. And that can be frustrating and agitating. And then that stirs up behavior. I wouldn't say I never use medication for behavior. I mean, we try to work around it, but if we have to, there's certainly times where you've tried everything else. You've tried modifying the setting. You've tried compensating for things that might be confusing, and you end up needing medication for behavior. So there are a number of different types. I mean, I'm happy to talk about that if you'd like me to. You want me to go into some examples?
Let's kind of shift gears a little bit and talk about, those behaviors are very difficult to manage, no doubt. And there does come a time in the life of many people who have dementia where it is no longer possible to manage those in the home setting, or perhaps not in the best interest of the patient and the family. Let's turn now to Beth Janney, and I'm going to ask her to address that. Beth does training for professionals and for individuals in regard to behavioral issues and alternatives to managing those kind of things. Beth, would you spend a little bit of time talking about that?
Certainly. Dr. Kodsi alluded to it. At Morning Point, we really look and see what the trigger for the behavior may be. It may be how the caregiver approaches the person, verbally and or physically. It may be that the certain activity they find unsettling or uncomfortable. Bathing is a prime example. People with dementia quite often do not like the feeling of water spraying on the top of their head. So sometimes you have to think of other ways to do bathing and think outside of the box. We do a lot of training. We look at the timing that the behavior occurs. A lot of behaviors can occur in the late afternoon. And sometime I saw in the chat, one of the questions went by about having behavior at night, that the person's really disrupted at night. They can associate that with a thing called sundowning that has to do with a little disruption of the kind of biorhythms of a person. A lot of behaviors can happen when a person's bored. We see that most often. That's one of the most common, is because they're bored and they need something meaningful to do. And we address that every day, all day at Morning Point. So there's so many reasons, but it's very important to look at it. There might be an unmet need. Are they hungry? Are they thirsty? Is there a physical reason? Do they have a urinary tract infection? Are they bored? Are they scared? I saw something in there about hitting and biting. Usually they're scared of something. So you just have to look at all of those things and figure out a plan, figure out when it occurs and how in that instance to do it differently. So.
Yeah, and I think what you said is so apropos. All behaviors are communication. That's a way that
exactly right.
Words fail and cognitive abilities fail. That's how communication happens. That's what we all do, even as healthy adults. Certainly children do it, and certainly people with dementia do that. And while I've got your attention, Beth, I do want to just remind everyone that considering alternatives like assisted livings is not a failure, and it's not a giving up by any stretch of the imagination. It is, in many cases, a natural course of events. And in many, many cases, and I know in my own case with my mother, it was a very hard decision to make. But I see the difference now in the quality of her life and in the quality of my life and my sisters who share caregiving responsibilities. And I have not regretted one single minute. Even during COVID, when I couldn't go see her, I never regretted her being there, because I knew that she was having her best life. And that was everything to me. So that's, I guess, a commentary more than a question. Let's talk a little bit, Dr. Kodsi, about some of the questions that are in chat. Rachel, can you direct some questions our way?
Absolutely. We have one that just came in from Lois that is similar to one that we hear frequently from other people. And she's asking about how common is loss of appetite. We often hear people say, my mom or my dad doesn't want to eat the foods that they've always loved. I'm worried about their nutrition. I can't convince them to eat anything. And Dr. Kodsi talked about that.
Sure. And that can be a little challenging because one of the most common side effects of some of the medications, the Aricept, the Exelon, the Reminil, can be a loss of appetite. So you want to make sure that that's not something that started when the medicine was started or when the medicine was increased. Don't see it often, but we do see it. So that's something to think about. Also, with people with dementia, I'm sure those of you who are caregivers have seen this, there can be a change in their taste. I don't know if it's really a change in their taste or if it's a change in the way they perceive the taste of things, because that's really what Alzheimer's and other dementias affect, is how we perceive things. When they see something, they think they're seeing something else. Maybe when they taste something, they think it doesn't taste like it used to. And so they don't enjoy it as much as they used to. And so that may affect their appetite. We also have to keep in mind that especially early on in diseases like Alzheimer's, there may be a significant amount of depression. If someone is still aware that they are losing their faculties, they're losing their memory, they're losing their ability to think as sharply as they used to, that can trigger a significant depression, which can affect appetite. So there are a lot of things to think about with appetite change in Alzheimer's disease.
You mentioned depression, Dr. Kodsi. That's one of the things that I often hear caregivers express concern about, is the changes in personality that seem to occur. They will often say, yeah, daddy's memory's not good, but more importantly, he's just not himself anymore. And those personality changes can be really, really disturbing and upsetting.
Absolutely. And I think that's one of the, and we've talked about this before, Amy, that's one of the most difficult things about Alzheimer's disease is they look the same on the outside. So you expect the same behavior. And it's very frustrating for families. They expect this is the same person, but what's going on the inside is not the same. And that's what makes it so challenging.
Yeah. I once heard it said by a caregiver that, my dad's not who he was before. And me asking him to be who he was before because of the physical changes that are happening in his brain, that would be like asking someone who has no legs to walk across the room. I would never do that. So I would go help that person. I would go to that person. So I try to go to my dad. I try to go to where he is and not be upset that he's not who he used to be, or that he may not know who my children are, or sometimes who I am. So finding that connection is so challenging. And while it can be heartbreaking, there is also such a reward in that, such a comfort in that connection. It's very, very important. Rachel, what's happening in chat?
A lot is happening in chat, actually. Cindy has a great question for us, and she's asking about the best place to find local support groups for caregivers who take care of individuals with dementia.
Gosh, Amy, I'm not sure where to direct them.
Well,
Amy, would you like to go?
That's the person. Ashley is actually a support group facilitator for the Alzheimer's Association in Franklin. Can you share, Ashley, a little bit about the support groups and how that works?
Absolutely. So right now, the Alzheimer's Association and all of the Morning Point support groups are virtual. So that does provide the opportunity to find one that you can access from home at the time that works for you. You can contact the Alzheimer's Association, or you can contact a Morning Point to get in touch with your local facilitator. And these are great groups because it really is a group of caregivers that have walked through all the stages of this process, or at different stages, that can share resources with each other. So there may be someone in the group that has already dealt with something like getting a power of attorney, or those questions like, do I see a specialist, or who do I see? So you have caregivers that can give you their experience and help walk through that with you.
That's wonderful. And I also want to remind everyone that all of the Alzheimer's Association support groups are open to anyone, those that are hosted at Morning Point, at local churches, at civic centers, where the libraries, wherever they might be. Of course, they're all virtual now, and you can go to alz.org and type in your zip code, and it will give you a quick reference to the support groups that are available to you. And speaking of support groups, one of the first things I learned when I came to the association that I didn't know before I came here, even though I'd worked with seniors for 20 years. I started when I was 2, I like to say. I had worked for seniors with seniors for years, and I never really understood what communication often looks like with people who have Alzheimer's and how to be therapeutic about it. So Dr. Kodsi cheated again and looked at chat and saw that someone asked about what our thoughts are on therapeutic lying.
That's Amy Bulwer's famous phrase of therapeutic fabrication.
Yes.
So, it's not lying. It's just not disputing their perception of what is true. And I think in many ways, when you have an individual with a dementing disease, with something like Alzheimer's disease, as with any condition, you always want to do what is best for the patient. So if someone has a pneumonia, they need antibiotics. That's what's best for them. If someone has dementia, you want to stabilize the memory as best you can, and you want not to disrupt their daily routine or to aggravate them, their condition. And in some ways, disputing something they're saying or telling them something that may well be upsetting, well, then in that sense, you're not really doing what's best for them. So if telling them something that's a bit of a fib, so for example, if unfortunately a spouse or another relative had passed years ago, and they ask, oh, when is she coming home? Then to tell them that, oh, don't you remember she died 5 years ago? That's not really doing them a favor. That's not doing what's best for them. Telling them, oh, she's out to the store, she'll be home later today, why don't we go, play a game or eat some lunch? That's going to be better for them, and it will keep them happier. So I think doing things like that, it's not that you're lying to them, it's that you are not disputing their perception of what is real. And to that point, I think it's really important to point out, and we talk about this a lot, Amy, families always want to help. So when they say, oh yeah, it's 2022 this year, saying to them, oh, don't you remember? It's 2021. I know you remember that. Come on, what year is it again? That doesn't help them. And you want to help and you want to do what's best for them, but that can frustrate them because they may realize they've made a mistake, or they may not realize they made a mistake, and now you start an argument. So unless they say something that is dangerous, like I tell Amy, I'm going to get the guns out of the cabinet and go after the neighbor, that you should probably dispute. But otherwise, if they say there are kids in the yard, the sky is green, there's no reason to correct them. Now, if they say something that's frightening for them, so if they say, oh my gosh, there are kids out there and they are coming to get me, don't you see them with the sticks and the bats? Then also it's not always helpful to say, oh, no, look, there's nobody there. That doesn't necessarily reassure them. And then you're negating their belief. So what you want to do is try to play into what they're saying and say, oh, I see those trees out there. I see exactly why you think those look like kids. But look, see, there's a tree and you see the branch, and you may be able to talk them into it. Or if they're not looking, you can say, oh, I went out and I looked and I see exactly what you're talking about. I saw, be it a tree, or I saw a dog run across the yard, something that validates their belief that they saw something, but doesn't contradict them and tell them you were wrong. And that's a challenge. It's very difficult. That made me think of something else, but now I've forgotten.
I think too, what you're saying is absolutely spot on, and redirecting that behavior, redirecting what's going on by engaging them in something that that is distracting. I've often heard you say that, ice cream is a miracle drug, because it's very therapeutic sometimes to say, if they begin to escalate and get upset about something, to say, hey, you want some ice cream? Who doesn't love ice cream, right? Stopping that cycle, whatever it takes to redirect them. Or and I'm going to throw this one at Beth and let her talk a little bit about how activities are such a great way to do that. Beth, can you comment on that? I know Morning Point has a lot of pretty great programs that address that.
We do. And again, I think I said before that one of the triggers for behaviors is being bored. And I bet people do not realize that in our Morning Point communities, in the memory care part of our communities or memory care buildings, that we offer the same activities in our memory care buildings as we do assisted living. In fact, we offer more in the memory care department, because we offer group activities and individualized activities. And we do the same thing. We have music, we have reminiscing, we dance, we have exercise every day. Sometimes we have exercise like a routine, like chair yoga or something. And in the afternoon, quite often we have exercise in the form of a game. We have memory care residents playing chair volleyball and bocce, and we do trivia, we do crafts, and we all accommodate it for how each resident can participate and have some level of achievement and fulfillment from it. Everybody has a spot, because I know when I say that, like chair volleyball, somebody be like, oh, my mom could never do that. Well, we find a way for them to be able to be engaged in the activity. And we offer also, we have outings, we party a lot. We celebrate days, like we have Cinco de Mayo coming, we have the Kentucky Derby, we have birthday parties. We celebrate and have fun a lot. I encourage caregivers at home to remember to think about having some fun. Music is a wonderful thing to do with your loved one. It can awaken the brain, it can change mood, it can be calming. Music from their usually teenage years and young adult years. Dance with your loved one, sing with your loved one, have a little fun. It can relieve some of the stress for both of you. Also, if you're going to do activities with your loved one at home, break it down into simple steps. If your mom was such the mom and she liked to set the table, instead of saying, Mom, go set the table, say, hey, Mom, come help me. You always set the table so beautifully. Here, will you put the placemats in front of each chair? Now, hey, will you put the plate in front of each chair? Because they can manage that and still contribute and still have that feeling of accomplishment. And that's what we're all after. At Morning Point, we focus on not if we do a craft and the craft doesn't turn out like the prototype, we do not care at all. Our thing is, did you have fun while you're doing it? And that is our focus, that quality of life and having a good time.
That's awesome. I want to move in. I remember back at when COVID, of course, had everyone locked down, and my mom, I mentioned, is at an assisted living facility. And I called her one afternoon. I said, well, what have you been doing, Mom? She said, well, we got to play bingo today. And first, red flags are going off. What are they doing? And she said, it was different because we all had sat outside of our room in our chair, and the activities director, and I can't remember her name, she used her name, stood at the end of the hallway, and she had a megaphone and she was yelling out the numbers. And we played bingo, and I thought that is so awesome. And I was really jealous. Here I was sitting, Zooming all the time, not getting to be around people. And I loved that she had a way to get some social connection, because like we talked about before, not only, is fun an important part of life, but it's an important part of keeping our brains active and keeping us engaged in what's going on around us. So kudos to those who find ways to do that. Dr. Kodsi, before we get too far into our time, I know one of the most common questions that we often get that people want to understand is the stages of Alzheimer's. We often get questions about, do you think mom's in stage 7 or 4 or 3? What's the latest in regard to the different stages?
It's a loaded question when you ask me, because I'll always give this. I am not a stager. I think it is helpful to be aware that there are stages to Alzheimer's disease. And in that sense, I think it's helpful because if people read about the stages, and you could read about 6, you could read about 7, they describe different behaviors. Now, that doesn't necessarily mean that each behavior only exists in that stage, but it gives you an expectation for things you may see. So you are prepared for things that you can see as the disease progresses. I'm a 3-stage person, mild, moderate, severe. And really that's because to me, that reflects a treatment plan. So if someone is mild early on, then I'm really focusing on treating the memory, using the medications, trying to do things to maintain the memory function. And that's the main goal. When you get to the moderate stages of Alzheimer's, now you're treating the memory and maybe some behavior issues. And then when you get to the severe stages of Alzheimer's, you are more likely treating more behavior than you are memory and support.
Yeah. And so that we cover everything that we promised we would cover, I want to ask about the over-the-counter medications.
Sure.
The things that, well, it's kind of a twofold question. So I'll ask one and then I'll come back with the other. Are there over-the-counter medications that can help or hurt if a person has Alzheimer's?
So, there's no clear evidence, although Amy knows I have my little vitamin cabinet where I take all my supplements. There's no real proof that any of those truly help. They can't hurt you. Well, ginkgo can hurt you because it can thin the blood. So be careful if you're looking at ginkgo and you're on blood thinner, that can thin your blood and that can be dangerous. But there are certainly over-the-counter medications that, and I should not conclude without saying that also includes things like Prevagen, which really is an over-the-counter supplement. There's no good data. I think if it was really that strong, then it would be endorsed by medical societies. It would be out there as a prescription. There's no good data that actually helps the memory. I'm not telling you not to take it, just understand what you're taking. There are certainly over-the-counter medications that can be harmful, might not be the right word, but can be detrimental to someone who has Alzheimer's disease and other dementias. And I say that because in particular, the chemical that the Aricept and the Exelon and the Reminil are trying to increase, that same chemical can be blocked or decreased by some over-the-counter medications. And really the most common one that'll do that is Benadryl. And Benadryl is great for cold, well, for allergy symptoms. It's great if you're trying to go to sleep, it makes you sleepy, but it's bad if your thinking is already clouded because it has a very high risk, not always, but a very high risk of making someone who's confused even more confused. And keep in mind, that means that a lot of the over-the-counter sleep aids have Benadryl. A lot of the over-the-counter allergy medicines have Benadryl. You just have to be careful and check. And you can look up the generic name for Benadryl. It's diphenhydramine. You can Google that and write it down. But you're not going to see Benadryl listed in the ingredients. It'll say diphenhydramine. So something to look for when you're getting those sorts of things. Other than that, over-the-counter drugs, there aren't very many I'm concerned about. There are certain prescription drugs that can also block that chemical. Some of the older bladder control medications, the way they work is they block the chemical that makes your bladder contract. And that happens to be that same chemical that we're trying to increase in the brain. So a lot of the newer drugs don't get into the brain, but some of the older ones do. And in particular, one called oxybutynin, which now is out as a patch called Oxytrol. It may not affect everyone the same, but there is certainly a notable risk that can make the memory worse and increase confusion. So if you're looking for something for bladder control, some of the newer medicines have a much lower risk. Also sedatives. So I tell people that when you have someone with dementia, if there were a volume dial on the brain, you're already turning the dial down, more so for some than others. And sedative medications like Ativan or Valium or Xanax, they work by turning that dial down. So you're already starting not at the top and you're turning it down more. So you might get someone who's very calm. It's very possible, and they are effective, but you also might get someone who's very much more confused. Or when they come out of the medicine, as it gets out of their system, they may be disoriented as they come out. So again, I never say never, but those would not be the first group of drugs that I would use to treat behavior or to keep someone calm. Other than that, hold on. So that's the Ativan. I know I'm forgetting something. Another prescription drug. It's not used really as much. It's more used in the hospital, but it's called Phenergan. It's a nausea medicine, and it acts in a very similar way to Benadryl. And so that is notorious in the hospitals for making people with dementia much more confused. So something to avoid if your loved one has dementia and is ever in the hospital.
Yeah. So for the over-counter, the medications like for allergies, because everybody knows this is pollen central here.
You're right. Zyrtec is for the generic Zyrtec, the generic Claritin. Those are fine. Also for sleep, if they want to use melatonin, that's fine. All of those are acceptable.
Okay, good deal. Rachel, let's check in with chat. We haven't done that in a while.
Sounds good. We have a lot of similar questions coming in. One person is asking, are visits upsetting? So every time they visit their loved one in a memory care community such as Morning Point, their loved one is upset when they leave. And so they're asking, is it a good thing to visit them, or is it a bad thing to visit them and upset them?
That is so difficult. And that question comes up a lot. It is different case by case. I think if it all depends, Amy was talking about, and I was talking earlier about distraction and changing the subject and saying things that will make it easier for them to handle issues. I think it's good. They want to see you. They like that familiarity in a sense. I think a lot of places would say it's not always a good idea to come visit right away because they need to settle in some. And I think that's a good point. I think visiting is fine, but you need to be careful on the departure. What is the message on your departure? Is it, okay, we'll see you next week. It was good to see you. And then it's like all of a sudden they know they're not going to see you. Or is it, oh, we're going to go get some groceries and we'll be back in just a little bit. Oh, well, now they think you're coming and it's calmer. That also depends on how impaired they are. Are you going to be able to get away with that? Or are they going to see right through that? It all depends. I think visiting is a good idea. It's just going to be case by case and how you handle that. And it is challenging.
Yeah, it is. Ashley, can you talk a little bit about that? And also, I've had a lot of people feel very concerned because they say, mom wants to go home. Mom wants to go home. And sometimes even when they are home, they want to go home. But certainly when they're in a new facility or so forth. Ashley, can you talk a little bit about that going home thing and how visitation might make that better or worse?
Yeah, absolutely. And that is very common because sometimes a family member can be a trigger for a memory for that home or it was someone they lived with. So of course it would be natural for them to then leave with their loved one. So what I have found and our staff encourage with our residents is to time the visit. And as Dr. Kodsi said, the departure piece of it around something that will provide that next thing for them to do. So for some of the residents, that's naturally centering it around the beginning of a mealtime. So their loved one is leaving, they're, I'm going to run to the store, but your friends are already here to have dinner with you. I'll see you after I get everything picked up. So it's not saying I'll see you tonight. It's I will see you, but not setting a time on it. And often the mealtime is the easiest. If the mealtime doesn't work, then working with the program director, looking at the calendar on those programs that really draw their attention. And that is your lead into, because it's less helpful if they're left open to kind of figure out what to do next, because they're taking their cues from whoever their visitor is. So their cue then is, this is where you're supposed to be. And it's, oh, like you talked about with your mother, bingo's starting. So while you're doing this, I'm going to go run my errands.
Oh yeah, I get kicked out when bingo happens. Bingo, those are the sacred things. I'm no longer the favorite daughter.
No.
So Rachel, let's check in with chat again. I see chat just kind of going crazy, and I know there's a lot of things that are not going to get answered. But remember, folks, we have promised that we will address these questions. And if we have your email address, we will respond to your questions. So keep that in mind and don't be too discouraged, because we are getting close to almost being out of time. Rachel, let's go to a question.
Absolutely. One of the questions I've seen several times on here is about, what kind of conversations do you have with your loved one you believe has Alzheimer's or dementia, or the spouse of that person? Because there's a lot of denial around it, and the conversations are really difficult to have. So is there any advice for how to start the conversations and how to be convincing in asking them to get help?
I mean, I think it's always challenging. I think even if they're in denial, they most likely realize something's not right. And I think it's hard to ease into that conversation. And I think there's so many ways to do it. And it's case by case dependent. I think if someone really feels like their loved one is not going to handle it well, is going to really buck it, and they're early on, and you can't sort of trick them, then it also never hurts, to Amy's point, getting a cognitive evaluation. You can say, you know what, we're both 75 now or 70 now. I think we should both go and just make sure everything's good with our thinking. And if nothing else, we find out we're good and we can keep an eye on things. So it becomes going together. So you're not isolating them saying you have a problem. If it's clear they recognize there's a problem, or if they bring it up, well, that's easy then, of course. They say, wow, I forgot where my car was today. It took me 20 minutes to find my car. Wow, maybe we should make sure that there's not something, you don't have to say Alzheimer's. We should make sure I hear vitamin problems can give you memory trouble, or I've got a friend whose thyroid is bad and they had memory trouble. We should probably get that checked, and that's something we could fix. I don't think anyone is, well, I think the better part of valor is not to say, I'm really worried you have Alzheimer's disease, we should get checked out. I think the better part of valor is to say, hey, you know what? You're right. You've mentioned some memory problems. Let's go get that checked out, see what's going on. Maybe there's something the doctor can get you some medicine for, or like my friend who's got this or who's got that. I'm all about being direct and honest, but I just find that would probably not be the best way to get them to go to the doctor. And in many ways, no matter what you say, they're not going to go to the doctor. So then what you have to do is find something they want to go to the doctor for. And when they go, introduce the memory issue.
That's a good, another thing that I think has been helpful is, now that Medicare pays for the cognitive assessment through the annual wellness visit, I've had caregivers use that tactic. Well, we're going to get what we're paying for. We pay good money for our Medicare, so we want to get all the benefits out of it. Let's get them to do a cognitive assessment too. So, like you said, Dr. Kodsi, anything that you can do to go where they are, to make it comfortable for them, And that is a real challenge.
And Amy, let me say two, maybe three quick points in one, because I know we're reaching the end, but I remembered what I wanted to say before. In the example about the guns, I usually lead off from that to say, that brings up a point that if they have those sorts of problems, there really should not be guns in the house. And that can be a sensitive thing. Maybe you get them out and they don't know that they're out, but they shouldn't be in the house. And I see a lot of questions. I'm just glancing periodically about how do I know when it's time that my loved one may need to go to stay in a facility, or I didn't see this one, or maybe I missed it. How do I know when it's time that maybe they shouldn't be driving anymore? And my answer to my patients and their family or their families was always, if you're thinking it might be time, it's probably time.
Yeah, and I think that's probably why a lot of the people are on with us this evening is, that they have questions. What do we do next? Is it time to do something different? And while, none of us on this panel can tell you what to do and what's going to be the perfect solution, what you're doing now, reaching out, is so important. What you're doing now, seeking out people who can help you with your decision making. You don't know what you don't know, right? And once you know, you're still not necessarily going to know the perfect solution, but you can make an educated guess. You can make a move based not on desperation or emotion or fear, but based on what resources are, reaching out to the people. Everyone on our panel is available for questions. You can reach out to us by email. You can reach out to us by telephone, and that information is right there on your screen. If you have questions specifically for Dr. Kodsi, please be patient if you've put your question in the chat, because we will get to you within a day or two. But if you think of something at 3 o'clock in the morning when you wake up that you didn't ask, feel free to email me. I can field those questions to Dr. Kodsi and he can answer them in between all of his busy day. Beth and Ashley are also very receptive. They do a wonderful job as advocates for you in the community and resources for you in the community. And of course, myself, you have all of our information there. I'm sort of talking and killing time to give you guys that question, the opportunity to find that pen and pencil and write things down. We will do a follow-up email for those of you who registered as well to remind you of how to get in touch with us. So it is really hard for me when I see chat still going wild to say that we're going to have to wrap up for the evening, but we are. I want to thank Beth, Ashley, the Morning Point Foundation, and most of all, Dr. Kodsi. Dr. Kodsi, your voice, your knowledge, and your heart for the people who have dementia in their lives, it's extraordinary. And I'm so grateful that you spent your evening with us. I'm so grateful that you took the time and continue to take the time to offer these kind of opportunities. And we will do it again next time.
Always a pleasure. Thank you, Amy.
Well, we're going to wrap up now, folks. Again, stay tuned. I did see that the question was asked, will this be available to share with other people who may not, who weren't with us this evening? Yes, it will be. It'll be recorded. So it'll be available on the Morning Point Foundation website. So again, we'll follow up with an email and let you guys know how to find that. Thank you again so much, every single one of you. I always say that, caregivers may wear normal clothing, but they have their capes on underneath. Each and every one of you who's a caregiver, whether your mom's with you, whether your husband is in an assisted living facility, whether your loved one is halfway across the country, you're still a caregiver, and you still need that support, and you still need that validation, and you still need to be honored. And we honor you this evening, and we thank you for being here. Everyone have a great evening.
We hope you enjoyed this Caregiver Cafe, brought to you by the Morning Point Foundation. Please join us for future Caregiver Cafes as we continue discussions around senior care, aging, and the nursing workforce. Thank you for joining us. For more information, please visit our website or get in contact with a local Morning Pointe associate.